Okay. Ready. Ready? Okay. Okay. Good morning, everyone. Thank you for joining us. Those that are here in person and those that are online. My name is Dana Raz. I am Division Chief of Developmental and Behavioral Pediatrics here at Phoenix Children's. And I have Dr. Randy Phelps.
I'm a psychologist here at Phoenix Children's.
It is our pleasure to introduce our visiting professor here today, Dr. Carol Weitzman. Dr. Weitzman is a developmental and behavioral pediatrician and the co-director of the Autism Spectrum Center at Boston Children's Hospital and director of the Connecticut Center for Developmental Pediatrics. She is an associate professor at Harvard Medical School and professor emeritus of pediatrics at the Yale School of Medicine. While at Yale, Dr. Weitzman was the director of developmental behavioral pediatrics and oversaw the fellowship training in DBP. Nationally, she is a past president for the Society of Developmental Behavioral Pediatrics, a past chair of the American Academy of Pediatrics, section of Developmental Behavioral Pediatrics, and a member of the American Board of Pediatrics Subboard.
And Dr. Weitzman is also the author of the American Academy of Pediatrics Clinical Report Promoting Optimal Development, Screening for Behavioral and Emotional Problems. She is currently conducting studies to understand the healthcare experiences of people with neurodevelopmental disabilities and a multi-site trial to train primary care physicians to diagnose young children with autism spectrum disorder. We're thrilled to have her here today to speak about her important work on the Supporting Access to Care for Everyone, or SAFE initiative. And this SAFE initiative really provides guidelines for improving healthcare equity for youth with neurodevelopmental disabilities. Please join us in welcoming Dr. Carol Weitzman.
Thank you very much. Okay, I hope you all got the QR code and everything to get your CME. Anyway, I'm really delighted to be here. And I have to say, I was here yesterday with the team, and they are already, you all are doing really incredible work here in Phoenix. And I'm just delighted to be here to hear about it and to kind of help you energize the work that you've already started in such an incredibly thoughtful way. So we're going to be talking about supporting healthcare access for youth with neurodevelopmental disabilities. You can see I have my collaborators on the slide. I always feel like when I give this talk, they're kind of here with me. So that is also Dr. Cy Nadler, and who's at Children's Mercy Kansas City, and Marilyn Augustin at Boston Medical Center, because we've been kind of a unit, a team working hard on this project for almost, I don't know, you lose track of time, but I would say about 3 years. And so I always feel like when I give these talks, they're kind of standing by my side. All right, there we go. Okay, so I have nothing to disclose. I will say that this work was really made possible through support from the Maternal and Child Health Bureau and through the Developmental Behavioral Pediatrics Research Network, which is a consortium of 16 sites that have that conduct meaningful research around children's behavior and development. All right, so here's what I want us to do this morning. First, we're going to discuss the state of healthcare delivery for youth with neurodevelopmental disabilities. And we're going to do that because I want you to have some understanding of why we decided to take this on and why we think this is important. So we're going to look at this and try to think to ourselves about, what does it look like? The landscape for children with, and I'll call them NDDs, neurodevelopmental disabilities. What does that landscape look like? And again, where are the gaps? Why is this work meaningful and important? Then I will tell you a little bit about the SAFE initiative, kind of the key domains that we identified that healthcare settings need to consider to improve care access and outcomes for youth with NDDs and their families. And then if I've done a decent enough job of it, you're going to be wanting to know, what should I do? What can I do? And as I said, these guys are already doing it. So all you have to do is talk to them and you'll know what to do. But you're going to want to identify opportunities and priorities for medical education, clinical dissemination, advocacy, and research to support the healthcare of youth with NDDs. So I'm going to start with a video because honestly, I always feel like parents and people with lived experience can tell stories far better than I can about how they have intersected with the healthcare system. So this is Ellen Bannister. Ellen is a parent and she is a professional advocate. She's from Oklahoma. She's going to tell you the story about her son, Ben, who has intellectual disability and is on the autistic spectrum. Okay. As a grade schooler, Ben needed orthopedic surgery on both of his legs, and she has given us permission to share this story.
Preparing for this surgery, we asked if anyone had ever pulled off their casts, as Ben cannot stand to even have a Band-Aid on his skin. We were told it wouldn't happen. When I asked if we would need home health services after the surgery, we were told we wouldn't need them and that our insurance wouldn't pay for babysitting. We asked if he would need a wheelchair and were told no. After the surgery, we took Ben home with split casts up to his calf and long incisions along his ankles. He couldn't walk, so we found an old transport chair of my grandmother's in the garage to use. While he was sleeping, I showered in the bathroom next to his bedroom. I left him alone sleeping for 10 minutes. When I checked on him after my shower, he was lying on his bed in a pool of blood. Within that 10 minutes, he had pulled off his casts off his legs and pulled out both incisions, which were now completely open. I didn't realize it until years later when I was taking a Stop the Bleed training. But if I hadn't gone back in when I did, Ben would have bled to death in a few hours. The ambulance took him to Children's Hospital, where he was given ketamine for the first time. It turned out that he was allergic to ketamine. His skin became red and covered with hives, and he began convulsing as they tried to stitch up his legs. 6 people were trying to hold him steady, including me, his dad, and cleaning staff who had been called in to try to help. Ben was not admitted after the stitches and makeshift bandages were done, and we were 2 days to try to argue. We were given no follow-up instructions that I can recall. I asked what we could do to stop it from happening again, and the resident who was providing care said he didn't know. I asked if duct tape would work, and the resident said maybe. We kept our heads down and endured. It was only later after we spoke to other families with similar post-surgery experiences and found out that these events are fairly common for kids on the autism spectrum.
Just for the heck of it, what went wrong in that story? Just call it out. Everything. Name it. Just whatever, really quickly. What went wrong? No follow-up. Go right to the beginning. What else? No planning. They didn't take her so diminishing. She's like, my kid is like, it's not, I don't think this is going to go well. No. We'll find you. She finds a wheelchair in the garage that was her mother's. Or what else? I agree with you. He didn't get admitted. The kid comes in, he's pulled out his stuff. He doesn't get admitted. The resident says, yeah, try duct tape. That's good, right? It's really a horrifying story, isn't it? Pretty horrifying. It's very tempting to listen to that story and to think, well, that would never happen here. No. We're much better than that. And this is, thank God, I don't think an everyday occurrence, but things along this line happen all the time. And I feel like you all pulled out, some of the important things. They didn't take her seriously. They didn't understand the extent of this kid's disability. They didn't get it. They didn't listen, and they just really didn't understand that a child like this is going to have different needs. This stuff happens every day. Again, hopefully not to this extent, but this happens all the time, everywhere, every day. So we should just not make sure that we think, well, it's that children's hospital that doesn't know what's going on.
Preparing for the
Okay, so when we think about children with NDDs, we know that 1 in 6 youth have a neurodevelopmental disability, and that these children often have higher rates of medical complexity. And in fact, in a very recent study that was just done, they saw that over 40% of youth with chronic medical complexity are on the autistic spectrum. And when you look at all children with autism, 60% of those kids have medical complexity. So there's a very tight relationship between medical complexity and autism. But in fact, that very same population that has a lot of healthcare needs often have more barriers to accessing medical care, have much lower preventive well care visits, lower immunization rates, more challenges accessing care, and more foregone care, meaning care that is not completed. So that's kind of a bad combination, isn't it? Having high needs and more difficulty accessing care. And so no surprise, children with NDDs have worse long-term health outcomes and higher rates of mortality and morbidity. So we're going to spend a little bit of time sort of unpacking that on the next two slides. But these things, as you can see, have very, very real impacts on the health and well-being of children with NDDs. So we'll look at that on a couple of slides. So in this slide, there was a systematic review that looked at sort of all the causes and the cause-specific mortality of individuals with ASD. Now, some of these increased mortality rates can be explained by just what I was telling you before, medical complexity, right? So we know people with autism are 2.5 times higher risk of death than people without autism. For children, it's 12 times higher risk. I mean, that's a substantial increase in risk. And that females are at even greater risk than males, likely due to co-occurring intellectual disability. The leading causes without intellectual disabilities are the following. Okay, neurological disorders, including epilepsy, suicide, accident and drowning, and diseases of the circulatory system. So I think we should spend a minute trying to understand, like, well, what does that mean? So it makes sense, right? If I told you already there's higher rates of medical complexity, one would expect that their children are going to have, you would expect likely there be higher morbidity and mortality rates, right? But I think what's included here is the following. Likely, because of reduced access, kids present with more advanced disease, untreated disease. So by the time they present, they're more likely to have serious and dire consequences, including death. The other thing that I want you to take note of is things like suicide, accident, and drowning. So when kids do not access care, when we do not understand the mental health needs of the population, again, we see higher rates of mortality in the population. And we know that on average, people with autism die about 20 years younger than their non-autistic peers. That's a very substantial gap, and we cannot account for all of that just by medical complexity. It's kind of a constellation and a coming together of many of these things that we're talking about. Okay, on this slide, this is looking at the cause of death in adults with intellectual disability, coming from a very large sample of people, adults with and without intellectual disability. And what you can see, it's a busy slide, and I'm just going to walk you through it. What you can see is it looks at people with mild to moderate, severe, profound, and unspecified intellectual disability. I don't want us to get too hung up on that, but I do want to make sure that we look at a few points. So in this, they looked at kind of these cause-specific reasons for death. So you can see that all of the different causes, are located here in this column. And what you can see, all you have to do is look at the line. If it's anywhere to the right of the line, it means that people with intellectual disability had a higher odds ratio, a higher likelihood of death from those causes than people without intellectual disability. And I think that the take-home messages from this slide are the following. Number one, even people with mild ID were at higher risk in many cases for death, and that there's not everything crosses, on the right side, but a whole lot does. So we know that, in fact, again, people with ID are more likely and at higher risk for mortality and for death from these causes. So if some things, I think what I would say is if there are things that are very common also in other populations, you may not see that there's more. And that was the most I could kind of discern from that, but it's a good question. So we know in this group that the difference in age at death between adults with and without ID was about 13 years. And it varied if you had mild or more severe ID. And so if you had more severe profound ID, it was about 17 years. So I think we've established here these mortality rates are much higher for people with NDDs. Okay, when we look at youth with NDDs in pediatric hospitals, we now know that acute care admissions for a primary mental health reason account for about 20% of all pediatric hospitalizations. Who are trainees here? Show me. Okay, are you guys admitting lots of kids with mental health problems these days? Is it a decent and substantial amount of the kids that you see? And of those kids, just give me a nod, or a lot of those kids have co-occurring autism or a neurodevelopmental disability? Yeah. So we know also that that when we see this, that autism is among the most significant predictors for prolonged mental health hospitalizations. And again, just anecdotally, are you guys seeing that these kids are staying longer in the hospital? Yeah. So that's kind of the universal experience across the country. There are also multiple reports of increased rates of physical and pharmacologic restraints during hospitalization for autistic youth. So we wrote a paper about a year ago, and it showed that kids with autism were more than twice as likely to be restrained even after we controlled for behavioral health problems. So just having autism by itself after controlling for a whole bunch of other things, again, including behavioral health issues, places children more than 2 times at risk for having to being restrained. And despite their expertise, and it's interesting, I've been talking with people here about this, psychology, developmental peds psychiatry struggle to identify and respond to suicide risk for autistic youth. And we were just talking about this yesterday, that the standard tools don't necessarily work, but also people just don't screen because they sort of think, well, that's not really a problem in people with NDDs, despite the fact that we know that suicide risk is higher for people with autism and other NDDs. So again, we haven't really caught up with truth, and we don't always have good measures, but we're struggling with this. And behavioral health, developmental, and cognitive delays are among the most common conditions associated with aggression towards healthcare personnel. And this kind of relationship of aggression towards healthcare personnel often spirals into people being afraid to take care of kids with NDDs and using things like pharmacologic and physical restraint as a go-to. So why is this? Like, why is this where we've gotten? You know, I would say that if you probably, you know, as we've seen, especially since the pandemic, a spiking of children being admitted for mental health reasons, kids with autism, maybe it wasn't quite as common, but it sure is now. And so we have some things that are lagging. And I'm going to show you on this slide and the next 2 reasons why I think we can somewhat start to explain why is this disparity exist in kind of care for children with NDDs in hospital settings. The first is education. Many healthcare professionals report significant gaps in their training related to NDDs. Very few pediatric hospitals embed optional, let alone mandatory or ongoing education for staff that is related to NDDs. And again, when they do have it, it's often more optional, it's rarely mandatory, and it's rarely ongoing. The long-term impact of educational interventions are largely unstudied, and there are major barriers to representation of people with NDDs in health professions. So we're not educating our staff. And I've said this, you know, that I think the people who need education around NDDs, not always in the same dose, not always in the same frequency, but it's everybody from the moment you pull up to the hospital till the second that you leave should have some awareness of what it means to care for a kid with an NDD. And you know, the folks who you first encounter, who meet you in the parking garage, at the check-in desk, have an awfully big influence on how that visit is going to go. The second major reason that I think we have to think about is the idea of ableism. How many people are familiar with the term ableism? Okay, awesome. Most people are. So that's great. Ableism is really discrimination against people with disabilities, undervaluing people with disabilities, ignoring the unique needs of people with disabilities. And this can occur at the individual level and also at the structural level. So at the structural level, it means there are discriminatory processes and policies that systematically privilege the able body and fail to represent or meaningfully include disabled persons' voices. I would put out there, and you all can agree or disagree with me on this, but I would say that there was a bit of an ableist attitude with that in that video that we saw. They dismissed this kid as not having legit needs. And that was a bit of an ableist. I think they undervalued this kid and his needs. And so I would say that sort of feels like not a conscious, but an ableist attitude that was happening there. So in 2023, I'll just tell you these things that have been happening that have been somewhat bright lights on the horizon. The National Institute on Minority Health and Health Disparities designated people with disabilities as a population with health disparities to support research addressing discrimination and other barriers. And I think this was really important to understand and to really include people with disabilities as recognizing that they have health disparities. The second thing is the Heads Up Act, the Healthcare Extension and Accessibility for Developmentally Disabled and Underserved Populations, which seeks to designate people with intellectual and developmental disabilities as an medically underserved population. Again, that would be a really important thing. It changes a lot of stuff. It changes payment issues. It changes a lot of things that kind of incentivize people to take care of people and children with NDDs. It has not passed yet. I don't know when it will, but that's why it is so important. Okay, so by now I'm hoping that you are kind of seeing that people with neurodevelopmental disabilities have really significant problems accessing healthcare in, across all healthcare settings. And so that's why the SAFE initiative was born. The SAFE initiative, which is supporting access for everyone, is an interprofessional, stakeholder-driven initiative to establish a standard of practice in healthcare for supporting youth with neurodevelopmental disabilities. Now, how many people have heard the term autism-friendly? Some. Okay. It's kind of became a popular thing around the country, calling, about autism friendly. And we decided to use this term SAFE instead, because we think that care should not just be restricted to one disorder, but really to the broad landscape of neurodevelopmental disabilities, which includes a lot of other disorders. And that, again, this has really nothing to do with being friendly. It's nice to be friendly, continue being friendly, but it is more important that we talk about safety and we talk about access. So our consensus panel is here. That's myself. There's Dr. Augustin, Dr. Nadler. And the consensus panel was very, very deliberately selected because we included people from across the country who are doing work in this area and represented many disciplines. There's neurology, psychiatry, let's see, I'm looking at it now, neurology, psychiatry, occupational health, child life, hospital administrators, developmental peds. And then most importantly, we included families and we included adults with lived experience, because we really felt like if we're going to come out with a consensus statement saying what we think needs to happen, we absolutely needed to include the voices of the people who care the very, very most about this. So again, it was a very deliberate sampling of people, and it was an incredible group to work with. And I'm just going to show you a little bit of our process so you get some sense of what we did. This wasn't like we just sat down and kind of jotted it down and said, that sounds good. We went through kind of a very laborious process to come to this. We held a 2-day public forum, and we put out a public call for people to come and present clinical initiatives, research findings, personal stories and perspectives. If we ever do it again, we're going to get you guys to come and present at that. And we had more than 40 people who presented from across the country. And I've said this many times when I give this talk. I've been doing this for a long time. And you think you know something about something. And I'll tell you, listening to the stories of parents and people with lived experience telling their stories about medical trauma and the kind of big and small offenses that they experienced in healthcare settings was truly remarkable to me. It was very eye-opening how traumatic the kinds of trauma that people have experienced. And it just was a very eye-opening thing. And it really confirmed for me that we just need to do things a bit differently. So after that, we had a 2-day consensus panel meeting. Again, it was supported by the DBP Research Network. We brought everyone together. We used this fancy term called nominal group technique. And basically all it means is that we kind of generated themes based on what we heard from presentations. We did a very deep dive into the literature, which is very, very limited. It's there, but it's very limited. But we looked at all of it. And then we sort of generated themes, we grouped them, we reviewed them, we came back to large groups, and we just voted and voted and voted until we had something that represented the ideas and the opinions of everybody present, that we thought represented kind of, if you will, a consensus statement that would give some guidance moving forward. And this was our paper. And this came out last year, and that's what I'm going to spend a few minutes talking about. I'm going to come back to my QR code at the end and tell you a little bit about that. So we started off by talking about the foundational premises of safe care. And what we said is safe care is care that is individualized and care that people want, individualized and evolving with the changing needs of a person, accessible throughout the entire lifespan, equitable and respectful, defined and measured by patient experience, quality of care, and psychological well-being of patients and caregivers, and not just by the narrow interpretations of safety, efficiency, and remuneration. And that safe care reduces or eliminates the risk of physical and emotional harm to people, including accident, injury, restraint, and seclusion. It reduces poor quality, inadequate, and incomplete care, and it reduces foregone care, which results in untreated healthcare conditions and increased morbidity and mortality. Let me ask you a question. Do you think every person who walks into our healthcare settings deserves this? I hope that's a yes. I hope we're all on the yes page on this one. Does it surprise you to think that we had to put this in writing, that this is not happening, that we need to establish these foundational principles? It sort of surprised me. And doesn't it seem a little bit like a no-brainer? Like my sort of joke about this is like, I feel like people should ask me, really? That took you hours and hours of work to come up with that? It seems so darn obvious, doesn't it? But yet it's not what's happening. And so we needed to start by just saying, these are the foundational principles. This is where we start, even though it seems so obvious that this is what we all want to deliver to people when they walk through our doors. The key concepts we talked about were the following: training, communication, access and planning, health equity, and policy and structural change. So training, I talked a little bit about, making sure that people get trained, that they get the right dose, that it's ongoing when you need it, that it really ensures that people are going to be working much more effectively with people with neurodevelopmental disabilities. Communication, I'm going to show you a video in a moment that tells it way better than anything I could say. But the idea being that we must give children and adults an opportunity to communicate in the way that they communicate. So we see who has ever taken care of a kid. I know there's a lot of trainees here. Who has taken care of kids who are nonverbal, non-speaking? I imagine most of you have, right? Because people don't speak doesn't mean they don't communicate. And we don't always give them the opportunity to do that. But we must, because when we don't, we are denying people a right to tell us what they need. And so it's about learning how to incorporate that effectively into our healthcare settings. Access and planning is about being prepared, anticipating what people need. And I'm going to show you, I think, a really nice, vivid story that brings that point to life. But about in advance, especially of an optional visit, being able to anticipate what the needs are. Because guess what happens when we do that? When we do a better job of anticipating, we reduce the behavioral outbursts that happen. We reduce the aggression. We reduce staff injury. We reduce the need for restraint and seclusion. Health equity is all about really just making sure that everyone who walks in our door gets what they need, even if what we need is a little bit different. That it's not that you and I and everybody here gets exactly the same thing, but that people get what they need to be successful in their healthcare journey. And then policy and structural change, because the truth be told, you could be doing something really great and you could be doing something really great, but if the policies are not there, they're not really sustainable. So we need to make sure that everyone's doing it and that it's expected, not optional behavior. So I'm going to show you a video in a moment. This is Bob Williams. Bob has a 45-year-long disability advocacy and policy career, and he uses an alternative and augmentative communication device to communicate. He is the co-founder of Communication First, which is a nonprofit that is focused on ensuring the rights of people, the rights, the autonomy, and the dignity of people with speech-related disabilities. Some of it gets a little wonky in here, but just listen, you'll get the gist of it.
Pediatricians, hospitals, and others who treat a youth who they believe require but lacks effective access to AAC should have the duty, and equally importantly, afforded the ready means to assure they access what they need. Simply put, ignoring a child's need, ability, and right to express themselves, to be heard, as well as respect, endangers their health, well-being, and life.
So could you all hear that pretty well? So I'm just going to say that last sentence. It's really powerful. He says, ignoring a child's right to express themselves, to be heard, and to be respected endangers their health, their well-being, and their life. How many people have had an experience where you have communicated with somebody through their AAC device during a visit? Okay, I see a few people.
Pediatricians.
Okay, so let's think about, well, where do you start? It's very overwhelming to think about how do we change systems? And I am going to highlight some of the things that I think that are happening here in Phoenix, because y'all are doing really important and inspiring work. And I want to make sure we kind of talk about that. But where do you start? You know, how do you make changes? And I always say you start by just doing nothing. Start with it here in your head. Start with it here. Start with a mindset and an attitudinal shift and a belief that everyone who walks through our doors, no matter who they are, is going to get the care that they need. And I always feel like we tell people, well, good to see you. Check your disability at the door, because this is how we do things. And I think that the mindset shift is saying, how can we change the way that we do things to accommodate your needs? And that is a mental shift and an attitudinal shift. That's your first place to start. And then you start to look across your landscape. Well, what does safe mean to you? What does it mean in your personal practice? How do you conduct yourself? And what does your settings look like? Your clinic space, your staff, what training have they had? What training have you had? What is your entire institution doing? What do your community partnerships look like? Your profession, there's many professions, or at least a few represented in this room. For the trainees and the diverse learners who are here, what kind of exposure are you getting to education around this? Community presentations, CME offerings, research, and your advocacy agenda. And the next thing you have to do is to start to think, well, if I want to make change, where am I going to get the buy-in? And sometimes you have to look in funny places to get the buy-in, because sometimes the partnerships are not really right in front of you. And the people who are interested are people that have different reasons why they're interested. The quality officers are interested because of safety issues. The nursing folks are interested because their staff are afraid and they're getting hurt. So you want to find the people. Now, I'm going to compliment you guys, and I'm going to compliment you a bunch of times because I think you've brought together through a neurodiversity committee that exists here. I don't know if y'all know that there's a neurodiversity committee here. And if you don't, now you do. And it's a very interesting group because it cuts across a lot of different disciplines and people who come together with a lot of interest and energy from different perspectives. But that's what you have to do, because making these changes, I always say it's a team sport. It does not fall on the shoulders of one discipline to do this. And so you want to first get your buy-in, and then you want to kind of take a look around and say, okay, what is the current landscape? What are the strengths? I've now talked to people across the country, and I know there is a lot of good stuff happening in this space across the country. And that's exciting. There is a change. And again, part of it is because we're seeing these high prevalence rates, high admission rates, long extended hospital stays. And a lot of people are saying we have got to do something differently. So look, what are you doing now? What's going well? Why is it going well? Who's making it go well? Who are your champions? What training exists? What are the policies? Who's making those policies? Are they being implemented? Who are your community partners? And I'll tell you, your best advocates, your best voices are your community partners of parents of kids with NDDs and people with lived experience, because they have the stories to tell and they are the most invested in making sure that things go better for their children and themselves. What are the proactive strategies? What are they? How available are they? You can have the nicest kind of, behavioral support plan, but if you have to dive deep into your EHR to find it, let me ask the residents, How hard are you going to work to find that? You don't have to answer, but I think I know that the answer is you're only going to go so far. And it's not going to, you're not going to think about it with every kid. Oh, do they have a behavior support plan? And then if you click 50 times. So you have to make these things available and accessible so that our trainees who are busy people can find this stuff and make use of it and that it's valuable to them. I don't think it's fair to ask you to have to go like, I mean, the EHRs are tough enough. I don't think it's fair to have to make you go dig to find some information. The job is to make it right there so you can access it and use it to help patients. Okay, so I think the first thing you do is you start with a small victory. I don't think you have to change the world in a day. You start with a small victory because small victories get people excited, you feel success, and then you start to move on. And I'm going to tell you a story about a small victory. And as I always feel I must say is I can take no credit for this victory. This is all on our child life people who did this. Their ingenuity, you'll see their creativity. I just get to tell the story. All right. So this is the story. I think this boy is about 10. And this is what his mother said. Going to the dentist has always been a challenge. For several years, we have unsuccessfully visited various dental offices and have attempted several strategies to convince him to have his teeth properly checked. No matter what we tried, he was always uncooperative. He would refuse to sit at the exam chair. He refused to open his mouth, and he refused to have his teeth cleaned. Okay, so our child life people did something so simple, but so brilliant. They talked to the parent and they said, what does your child need to be successful? Not that hard a question, but they picked up the phone and what does your child need? And you know what they learned? They learned that this kid had a strong preoccupying interest in Steve Harvey. You know who Steve Harvey is? Does anyone else here have a strong preoccupying interest in Steve Harvey? You might after this, okay? You might after this, and you might all go home and want to watch like Family Feud, and that may seal the deal. But anyway, that was his thing. So this is what they did. They made a social story about Steve Harvey going to the dentist. First, Steve will sit in the dental chair. He does have beautiful teeth, I just have to say. And he will use a toothbrush and toothpaste to clean my teeth, and the dentist may use a little mirror to see the back of my teeth. And they gave that to them in advance of the visit to get him prepared. And honestly, that would have been enough, but look what they did afterwards. They made like a big giant blow up Steve Harvey. Like seriously, how creative is that? But look what the parent says. With this support, he was able to have a proper dental exam and cleaning for the first time in his life, and he did not need to be sedated. By the end of the appointment, he was requesting not to leave. And during our ride home, he said a few times, I want to go back to the dentist. It's amazing, right? Now, here's what I want to tell you. That is an awfully cute story, isn't it? But it's really more than being cute. Okay, so I want us to talk about why. When children have pain, especially, now I don't know about this boy, but when children who are nonverbal have pain that has not been detected, you know what they do? Anyone want to guess? What do? They cry, they get aggressive, and they hurt themselves. And I have seen kids with very severe self-injurious behavior. And it's all because of undetected pain, because no one looked. The other thing is, remember we were talking about foregone care. If no one's looking in the mouth and they're not brushing their teeth, a lot of times by the time kids present to healthcare settings, they have advanced dental caries, abscesses, very advanced dental disease, increasing the rates of morbidity. So while this looks like just cute, and again, I don't deny you, it is cute. It's more than that. And what I give the big kudos to our child life folks for is for a few things. Number one is they just did a little bit of advanced planning. And they reached out and they asked, and they used really a little creativity and ingenuity to come up with this strategy. And, honestly, be honest, if I told you for a kid who was always sedated for dental exams and fought it, and I said, we're going to just bring this big giant Steve Harvey cutout, you think it's going to work? What would you have all said? Be honest. You would have been like, absolutely not. So they believed, you know, by using proactive, preventive strategies, they could do it. And when everybody's like, oh, but it's so expensive, how much do you think it costs to laminate a giant Steve Harvey picture, right? I don't know, but I don't think it's that much. So I just think it's a great illustration. So what you want to do when you've had some success is build on your success, build it so that every clinic can have a Steve Harvey experience. Because let me tell you, for those dentists, how do you think they felt at the end of that day? They felt great. They felt great that they didn't have to sedate this kid. They felt great that they didn't feel like they were holding a kid down to sedate him and doing something under duress. You want every clinic to have that experience. That's how you get people interested in this work, because everyone wants to see that kind of success. So this is just an example of how you scale up and you start to develop things like this Thrive Guide, which talks about things that you can be doing across different ages to, to be aware of the kind of individualized care that kids need. At Boston Children's Hospital, we've developed something called a seal of approval, and we've certified more than 10 departments. And basically what it means is everyone gets to have this little sign that says we're autism informed. And all it means is that every single person on that unit has had some basic training in the care of children with neurodevelopmental disabilities. Now you would think, well, that seems really easy to do. It's actually not. Turnover is high, maintaining a standard, making sure everyone's trained. But it's also not crazy difficult to do. And all you need is people wanting to do it. And I'll tell you, the people who have this seal, they're very, very proud of it. They feel very good that they are delivering a higher level of care. We also have to think about what the physical environment looks like. So there's a lot of attention now going on. What do our clinics and our waiting rooms and our ORs look like? And are they kind of, what does the built environment look like? And there's a lot of people, as you can see, who are, thinking about this and writing about this. What I would say is, you want to go back and look at your settings and see, what do they look like? Are they working? Here's the thing. When the ADA was passed in 1990, it did a lot to change. It was really for all people, the American with Disabilities Act is really meant for all people with disabilities, but it really tailored a lot to people with motor disabilities who needed, used wheelchairs for mobility. So can you imagine like now coming to a hospital and seeing an elevator that's not wide enough to accommodate a wheelchair? Could you imagine that? I don't think so. Not really. I mean, there's always at least some way, right? But the people we're talking about often have less visible disabilities, but it doesn't mean that the healthcare settings, they are just as inaccessible in different kinds of ways. And that's the trick of it, is to figure that out. And it's a bit individualized, but I say, you want to go and you want to look and see what do the healthcare settings look like. We did a little exercise yesterday and we walked around with this crew, and we sort of went on a little field trip around your institution, and we looked around and we saw the things that we thought were really supportive and helpful for people with NDDs, and beautiful accommodations that have been put in place, and other places where we said, that could use a bit of a tweak. And I'll mention them a little bit, but some of them where you have spaces with nice dimmable lights, and I don't remember in your unit, Dana, where you have this phenomenal like sensory room. I wanted to go in there. I mean, really, I feel like you all, if you don't know where it is, any of your residents, when you're overloaded, go find that sensory room. It's a very calming experience. Bean bags, it's lovely. Sorry, I let the cat out of the bag. You're going to find like 30 residents like jammed in there someday, But they have sensory carts here that how many of them do you have? 30. These really cool things that they can use for kids who are needing to have, who are feeling a bit overwhelmed, overstimulated, and such, and they're really neat. So you want to, there's certain things that are kind of low-hanging fruit, and then there's other things that take more operational finesse, if you will. So for example, we looked at your check-in line when you come into the hospital, right? Is that what it is? It's the check-in. You look at the check-in line when you come in, and I could see that line can get really long. And for a kid with a neurodevelopmental disability, that could be a really tough kind of experience where you will see kids start to really fall apart. And it sets the tone for the entire rest of the day. And they're already doing stuff to try to fast track people in. So with some operational finesse and some tweaking, there's an opportunity to make a change there. But that one takes a little more coordination. Thinking about things like education, I just want to briefly mention there's a number of national initiatives happening. We weren't the first people to think about this, I'm just telling you. So there's the niche curriculum, which was developed by the American Academy for Developmental Medicine and Dentistry, and it helps embed fundamental developmental disability education into medical and dental school curriculums. The ACGME, which I'm sure all of you are familiar with, just had a big disability summit, and they are quite serious about embedding education around NDDs into medical school and curriculum across all aspects of medicine. So I think there's changes coming. It's very exciting. The other thing here is the Institute for Exceptional Care is building a web library of vetted continuing ed materials focused on developmental disabilities. The idea of this is you don't have to reinvent the wheel. You should tailor it to your setting, but you don't have to start it at zero. You guys, I know, have developed a huge amount of training here and programming that you're sort of rolling out to different people. And I think part of the question is, who should be trained? How should we be trained? There's lots of ways to think about this. Where are you going to get the best bang for your buck, if you will? And I would say anyone who's giving talks, think about what do your talks look like? Do you talk about this stuff? We should. I'll tell you, after I started doing this work, I went back to all my talks and I've changed a little bit to talk about the issue of healthcare access in all my talks that I give. Let me just do a time check and see how we're doing. We have 15 more minutes, right? Okay, so we don't have much more to go, but I want to wrap up sort of so that we have hopefully time for some questions. This was simply a framework that was developed by Autistic Doctors International. I feel like we've talked about this. S is about sensory, understanding people's sensory needs. P is predictability, telling people what you're going to do, going slow enough at the pace that people can respond. Many people with autism often will tell you, I understood it, but they went very fast. So knowing how to pace it, don't you do that with everybody? I hope a little bit, pacing yourselves. A is around acceptance. C is communication, and E is empathy. We've sort of talked about all of these, but the idea being that we individualize care, we accept people for where they are, and we meet them for where they are when they walk through our doors. But we must also take all the good work we do, and we got to write about it, and we got to do research, and we got to do quality improvement, because at the end of the day, the goal is not for you guys in Phoenix to do this and us and Boston Children to do that, and they'd be similar and different. But the idea is that we develop a standard of care and best practice so that ultimately we can develop accreditation in this area. We need to involve our communities. Our communities are like our best voices. It has to be bi-directional. We need to ask them and tell them what we're doing, get their advice, inform them of what we're doing, and learn from them. So we want to give them information and get from them as well. So think about who your community partners are. And I know you have a very strong family advisory council here that helps you and guides you. And I think it's really important to hear those voices. You're not going to always agree with everything that they're going to say, and they're not going to agree with everything that you do, but you want to make sure that we're all in the same room talking together. And then we need to turn to legislative advocacy. And I'm going to tell you, folks, this is not going to be the time right now where you're going to be seeing a lot of legislative growth in this area. And it pains me to tell you that, but it's true. And so this is a bit of a bright light. The Autism Cares Act was passed in late 2024. It was actually a bipartisan. I don't know if we have that anymore, but this was a bipartisan act. And it funds some of the most important healthcare research, training, and service delivery for people on the autistic spectrum. So, just keep in mind that we have had some victories, but I'm not sure that what's going to happen in the next few years. So I'm going to end with a couple of concluding things. Number one is, I hope I've convinced you that we want to develop proactive partnerships throughout the planning and the delivery of care, and involve everybody who has a stake in the game. And you know what? The people who don't think they have a stake in the game, show them that they do, because everybody does. Everybody does. So you want to help people and find those champions. Work towards systemic changes. We have to convince people to put in the upfront financial investment and resource allocation to achieve these long-term improvements in healthcare access. But again, we don't know that it's actually everyone always, I understand cost, really, believe me, there's no one who works in a healthcare setting that doesn't hear about cost all the time. But we may end up saving cost, saving money, when we reduce healthcare staff injury, when we reduce prolonged hospital stays, length of stay, when we reduce things like seclusion and restraint, all of those kind of things, when we reduce people coming with advanced disease that could have been treated earlier, those things are all cost-saving measures, but someone's got to study it. I'm going to leave you with this and then one final slide, and this is Patrick Forgy. Patrick is an autistic adult. He's a research coordinator, and he works at the LEND program in Indiana. So let's hear.
Not every autistic person has the same issues. Similarly, not every autistic person needs the same accommodations. Not every autistic person wants or likes the same things. Find out what the person in front of you needs, you want, what they like, and build the care and the plan around it.
So quite a simple but elegant statement. So I will leave you with this, and now I'll tell you about the QR code. I'm going to tell you sort of a sobering thing, but I'll try to leave you with an upbeat note. So if you had gone to our website, we had a website called Safe DBP, and I would say, go ahead and try to go to it. You won't be able to. It has been taken down by the federal government. It no longer exists. And the funding that we had from the federal government for the next stage of work that we wanted to do, which is about developing a safe champions network, has been put on hold. So that's very discouraging to those of us who have worked so very hard and who care about this stuff very much. But I will tell you, it kind of makes us, because we're a little tough about this, just kind of makes us double down on it. And we have no idea where our fundings have come from. So if y'all have ideas, you'll let me know. We have no idea, but that we just feel like we're going to still move forward because there is a lot of energy and enthusiasm for this to develop what we are calling a Safe Champions Network. So if you're interested in being part of this, we are going to start having kind of these quarterly meetings. You can scan our QR code. And I think our first one is on, don't quote me, because I think it's going to be on May 5th. And we're going to just start to share best practice and hopefully develop a national group of people who care about this stuff, want to share experiences, and kind of hopefully position ourselves to be able to have some leverage at some point when we are able. So I will leave you now with another QR code to get your CME. And I thank you for your attention and hopefully have a few minutes for questions. Thank you. And anyone online too.
Their mics. We got one comment through the chat already. It says, wonderfully inspiring lecture. Thank you. Was this recorded and available? So the answer is yes. If you go to the TCH index page, the fifth link down on the left is Grand Round schedule. It to the CME page. So click on that, and then certainly by tomorrow, it should be up to the archive tab.
So for all our trainees, I'm curious, what do you think? How does this touch you guys? What's your experience?
I feel like with prolonged hospitalizations, we end up getting a lot of medication.
So we said use a lot of medication. So for kids with, I'm just saying, I don't know if people with prolonged hospitalization end up using a lot of medication. Which ones and why?
Mostly ones that either primary affect us sleep or secondary affect us.
To help enhance sleep or to kind of sedate kids. So what you're saying?
Yeah.
Is that everybody sort of having that experience?
I feel like I've had one example of a kiddo that I've taken care of quite a bit for a lot in his ASD and team and his like primary care doctor. And I think I'm sure some of you guys know him. Have done a good job of creating a plan for when he's in the hospital and having like schedule for him because he's here kind of quite a bit because he's got a lot of chronic issues. So I've seen kind of the other side of that where having kind of that plan that's focused on the individual. He loves playing. So like, talk to me about this. If I'm frustrated, do this. If redirectable by this, and it stays outside his door. And there's also like whenever he gets admitted, they put it on the board and he knows what to do. So I think it creates a lot of like consistency and kind of a routine for him, even when he's in the hospital. And I think that's quite beautiful. And I think that's something that we should move towards for all of our kiddos. And I think, you know, it takes time, as you've been talking about, to kind of get there. So
I hope that people on Zoom can hear what he says. There's no way I can repeat that whole thing. But let me tell you, you go Phoenix Children's. That is awesome. That's how we should be doing it. And it's great that you're seeing it. And that is exactly what we should be doing, is recognizing that kid needs something a little different than the kid down the hall. And by doing it, and I'm going to put you on the spot to ask you this, as your resident, right? As a resident, how does it feel to see that versus seeing a kid who's being sedated or in some stripped down room that can't leave their room?
yeah, it feels much better, and it feels like we're caring for him as a whole, not just kind of the medical complexities. So and he's much happier. And I think sometimes we divert to like, oh, he's frustrated. But I think as somebody that's cared for him quite a bit, I can de-escalate. And I think that's something that we're getting used to as kind of a medical team and as a hospital and medicine in general. So.
That is a really great and inspiring story. That's what we're hoping to see. It's what we're hoping our trainees learn and that we never get used to. We never really get used to the idea that we're going to sedate or restrain kids as a truly viable option. Because you now know, here's the thing, you now know that it can be done and it can be done well. And so when you next ever see a kid where it's not going that way, now you know that things like de-escalation, individualizing care, that there's ways to take care of kids. So now you can't unsee it. So guess what, Tad? You're it. You are now tasked with providing safe care in any institution that you go to. Anyone have any questions? I don't know if we have time for any more questions.
Another comment that made me think of, like, we have seizure action plans, we have asthma action plans, we have sickle cell action plans. At least I don't see a lot of autism action plans. Like, we see it in the charts all the time. When I have a kid with sickle cell, that's the first place I go look. I look for their sickle cell action plan and I figure out what this specific kid needs compared to all the other ones.
Spot on. So these guys are working on this. They have developed like an adaptive care program and training. They are working on it, but you have it exactly right. And that's what I was saying earlier. You want it so linked. Like, if you see a kid with sickle cell, I got to find their action plan. That's what these guys are going to get it to. So that when a kid with an NDD comes in, you're like, I need to see their NDD action plan. That's exactly what but it has to be automated. It has to be, and honestly, to me, the best way to be doing that is that parents can fill things out through your patient portal, and it goes right into that action plan, and that you guys don't have to search for it, but it's also in your mind. Oh, kid with a neurodevelopmental disability, just like a sickle cell or an asthma action plan, I gotta find their action plan. That's exactly right. I love that. And these guys are working on it. They're working hard on it, I will say.
One person in the Zoom audience wants you to go back one slide to show your QR code again.
Okay, good, because they want to join our Safe Champions Network, our unfunded Safe Champions Network. Yes.
One recommendation, like also to advocate for in general, is like to have more NND residency programs. Currently, there's only 8 across like the whole US. So just like even like it's a long run, but like just to add.
So having more ADD residency, which is part of neurology, and I'm going to say it's my part as a developmental piece, having more people go into these fields. We could create more training programs. We actually just need the people to go into them. And that's a whole separate talk, but we fill our programs at about 50% of our programs. And despite the fact that 1 in 6 children have a neurodevelopmental disability, only about 30 people a year go into developmental and behavioral pediatrics. And we have about 700 practicing DDPs in the country, not 7,000. 700. And so you're singing my song. You're singing my song.
Maybe that'd be a good place to end. Why don't you give a 1-minute plug for all the residents to why they should consider being a
safe champion. Oh, why you should be? Oh, we get to work like this and it's actually, you know what, I'll tell you what, I'll give me my 1 minute thought. A lot of what drives you guys, I don't know actually what drives everyone's going, but number one, you don't have enough exposure to what DBP is. And everyone thinks, oh God, that's such a depressing field. Does this look depressing? It's not depressing. We go on a journey with families through their lives and we support them and we actually optimize care. And here's one thing I'll tell you. I wrote a paper that showed we were a few years ago that showed we were the lowest paid subspecialty in all of pediatrics. And I would say that is not a good advertisement to go into the field. However, we just submitted a revision to that. And we relooked at the data and guess what? We're not so bad anymore. We're not so bad. I think we're actually doing better than Gen Peds. So there you go. You'll make a good living. You'll make a good living. You get to go on a big journey with families, form enduring relationships, have great colleagues. What else do you need, right? Thank you all. I hope not really a lot. Not really a lot. Thank you all.